Right, what I'd like to do today is the examination of the shoulder joint, and Andy's going to help us with this. Whenever you're thinking of examining your patient, you've got to have taken a good history to start with. So you should have some idea of exactly what you're looking for with the patient's shoulder. However, the shoulder is a very complex joint. So if you think that you're fairly sure of the diagnosis and you only go for that, just one test looking for that, then you're likely to miss something else that might be there with the shoulder joint. There's about 129 different tests for the shoulder. So today we're just going to do a few of those that I think are more relevant. The first thing you have to do when you're examining your patient is to get your patient to take his top off, his or her top off, in order to expose the area where you're examining. Watching your patient do this is often quite helpful with shoulder problems because you can pick up whether or not they're actually guarding the shoulder and how they're actually taking their shirt off. So take your t-shirt off, Andy. And Andy seems to have absolutely no problem with that whatsoever. You need to be organised when you're examining the shoulder joint and have a good routine. So what we're going to be doing is the same as most joint examinations, which is look, feel, move, and then do special tests. So what we're going to do first of all is to look at Andy's shoulder, and you're looking from the front initially, and what we're looking for here is his pectoral muscles. Is there any wasting at all here? In the acute situation, you'll be looking at the clavicles here to see if there is any bony deformity, such as fractures or AC joint dislocations. You may, if they've dislocated the shoulder, you may actually see a step in here, but you see that better from behind. Just turn around. So from the side, you're looking, just pop your head straight, so just in a neutral position. You're looking at the contour of the shoulder here. And then you get your patient to turn around again, and you're looking here at the scapulae, looking at the muscles. So what you're looking here for would be, is there spasm here in the muscles? Is there wasting here in the muscles? And when you're looking from behind, you're looking particularly here in the area of infraspinatus. If you've got a patient of Andy's age and they have infraspinatus wasting, you're thinking maybe of a suprascapular nerve problem. If you're more my age and you have this wasting, you're thinking more of a rotator cuff problem. You're looking at the muscle here, which is the supraspinatus, but in someone that has good muscle bulk, you often won't see that too well because the trapezius is overlying it. Just turn around again, Andy. Right, so we've looked here. What are we going to do next? We're going to be palpating. And what we're going to be doing is going from the medial border of the clavicle. So this is the sternoclavicular joint, and we're going to ask Andy to tell us if there's any discomfort. So we're palpating that joint, and then we're coming across the clavicle. We're coming here to his AC joint. And then if you just come slightly anterior to that and put him into slight extension, and you're feeling there, which is called Codman's point, which is where 3 of the rotator cuff muscles are inserted. Is that uncomfortable? Where a lot of the rotator cuff muscle, rotator cuff pathology actually occurs. Just turn around, and any tenderness here on the back here? Nothing there at all? Oh. And then the other thing we're looking for on the back here is any winging of the scapulae. And winging is where the medial border of the scapula comes outwards. And winging of the scapula tends to occur with things like shoulder instability, weakness of the shoulder stabilizing muscles, long thoracic nerve damage, and rare things like facioscapulohumeral dystrophy and that type of thing. So that's with winging of the scapulae here. Okay, well, when we've got him in this position, examination of the shoulder is never complete until you've actually examined the neck as well. We don't need to do a full neck examination for the purpose of this, but palpate here along the spinous processes, any tenderness. along the muscles on the side, paraspinal muscles. Flex forwards, extend. Any discomfort? Fine. Look over to the curtain to your right, look over to the curtain to your left. Okay, that's fine. Put this ear on your shoulder. And the other way too. Nothing? And then you go to a Sperling's test, which is get your patient to extend the neck, go slightly to one side, to the side where they're getting their pain, and then you press down on the vertex there. Any pain? And that will tell you if you have any nerve root pain. They'll often get pain going into the shoulder or even into their arm. Right, just turn around again, Andy. What you're looking for next is range of movement. And the range of movement, it's a multi-directional joint. So just pull your arm forwards and up over your head. This is forward flexion. And you can see that goes up to about 170 degrees. Come down, and then you go out sideways and up over your head. And that's a similar 170 degrees. Then you go, put the patient into extension, just stabilize the scapula, go backwards. Just fine, just go back. Just keep your arm, hand pointing like that, and just go backwards. And that's normally around 60 degrees. You then go into internal and external rotation. Put your hand across your tummy. Keep your elbow at the side. Go into external rotation. And the reason I say keep the elbow at the side, if you go to full rotation there, if you then pull up, you see you get a lot more external rotation. So if you're going to document this, it's important that you actually know what position you've got your actual elbow in when you're testing for external rotation. And you're comparing the two sides all the time. The internal rotation, just turn around to the camera, put your hand behind your back, and then touch up your back as far as you can with your index finger. Now he's got very good movement here because he can touch right up to the spine of the scapula here. That's around the sort of T2, T3 area. And then you document that. What we're going to do now, he's done the active movements. So what we're going to do is to do passive movements now. So we're going to take him up. When you do the active movements, patients will only usually take it to the point where it's uncomfortable. So what we do is to take it up as far as we can, and then you can just stress it slightly. Abduction, we'll just take his arm out. Extension. And then the rotation is, we tend not to do too much here because we're going to test do the special test for the actual rotator cuff and various other things. Right, so that's passive and active range of movement. Then I'm going to look at his rotator cuff. And the rotator cuff is 4 muscles: supraspinatus, subscapularis, infraspinatus, and teres minor. Now, 3 of those muscles insert into the greater tuberosity, which is supraspinatus, infraspinatus, and teres minor, and subscapularis inserts into the lesser tuberosity and the neck of the humerus. So in thinking about that, if you've got the tenderness there in Codman's point, then you know which muscles actually insert into that area. As I said before, there's about 129 tests for the shoulder. I'm going to just show you 12 today. Okay. Right, come over this side in order to demonstrate my first test, which is called the lag sign, which when you're looking at rotator cuff tears, you get your patient to keep their elbows by their sides and both sides go out as far as you can. Okay, keep your elbows tucked into your side, and then you push out a little bit just to try and extend that, and then you let the patient just stay there. Now, if they've got a rotator cuff tear, what tends to happen is this: the arm that's affected will just drift in. So it just drifts very slightly, maybe 10-15 degrees or so. And that's what you're looking for with this, what's called the lag sign. And that's a rotator cuff tear. Let me just come back over this side. Then we're going to test specific muscles. So if we look at subscapularis to start off with. Now subscapularis is an internal rotator of the shoulder. So what we're going to do is to do two tests for this. One is called the so-called Napoleon test, and you ask your patient just to press there into the tummy. So press and then relax. So what they're doing is trying to do this movement by pressing into the tummy. And what happens if they've got a subscapularis tear is their elbow tends to go posteriorly because they're trying to pull everything back this way rather than rotate. They're pulling everything back. The other test to do is put your hand behind your back, Andy, about to here, and then you put your hand on theirs and ask them to push against you. Push. So what we're doing is this movement like this in order to test the internal rotation against resistance. So that's called a lift-off test. Okay, relax. Okay. The next test that I'd like to actually demonstrate to you is for supraspinatus problems. Now for this one, what you do, you pull this is called the knee test, stabilize the scapula, put the arm into 90 degrees of forward flexion, rotate, just rotate, and then we press. So keep your arm where it is, keep your arm there, keep your arm there. Any pain? And relax. Now, that test is called the Nia sign, and that's a test for supraspinatus and rotator cuff impingement, but it's also positive sometimes with biceps tendinitis. Right, what I'd like to do now is just a couple of tests looking at the supraspinatus, which comes across here and then inserts into the greater tuberosity. Now the first test that I'd like to show you is called the empty can test. And for that, you put the arm into forward flexion at about 90 degrees with a slight adduction. You then get them to turn their hand down like that, as though they're emptying a can. And then you press on it. Is that painful? No. What you're looking for is pain here. Then you get them to put their hand up as though they're holding the can then full. And you do the same again. Now a positive test is of the empty can test is it's not painful when they're holding it up like that, but when they go into medial rotation as though they're emptying the can like that and then put pressure on, that's painful. And that's because you're then impinging that supraspinatus tendon as it comes in that subacromial space. There's another test that's similar called the Nia test, where you get them to lift their arm in the scapular plane now though, and you do an internal rotation. And if that's painful, that's called the positive Nia sign. Now, a Nia test is when you then inject the shoulder with some anesthetic, and then 5 or 10 minutes later, you do the same test all over again. And if the pain is gone, then you know that your diagnosis is then correct, because that impingement then on that supraspinatus is then gone. Right, the next test I'd like to show you is called the Hawkins or Hawkins-Kennedy test, and this is for subacromial impingement. You get your patient nice and relaxed, you forward flex their shoulder to 90 degrees, you fix up here on the shoulder, on the scapula, and then you medially rotate their humerus. And what you're looking for there, any pain? No. What you're looking for there is pain in the shoulder joint here, where you get impingement under the coracoacromial ligament. The next test I'd like to show you is for the long-headed biceps, which is called the Jurgensen test. And the Jurgensen test is where you get your patient just to flex their elbow to 90 degrees in full pronation, and then you ask your patient to supinate their hand. So I want you to move your hand like that, okay, against me. Okay, any pain? No. And if you've got a long-headed biceps problem, then that is uncomfortable. There's also a speed test where you get them to flex the shoulder to 90 degrees, supinate their hand, and just do that movement there, okay? And that's also a biceps test. Right, so there's a couple of the muscles there isolated. What we'd then like to do is to check this AC joint, and a couple of tests for that. It's called the SCARF test, where you get or the cross adduction test, where you get your patient just to push their arm across their chest, and then you push slightly. Any pain?
No.
And if they've got any AC joint pathology, that will be uncomfortable in this area here. Another test for both AC joints, and this is also for a labral test or a SLAP lesion. SLAP lesions, SLAP stands for superior labrum anterior-posterior. And the test that I like to do is called the O'Brien's test, where you go into forward flexion to 90 degrees, you adduct about 10 to 15 degrees, and then you get them to medially rotate. So I want you to do that movement, okay? Any pain?
No.
Now, if it's painful, then that often tells you that you've got a problem with your AC joint. If it's painful and also has a click, then that tells you that you may well have a labral tear. Now, there's just a couple of other tests I'd like to show you. One is called the apprehension test. You can do it in a standing position, but you're probably better doing it with a patient nice and relaxed laying down. So if we can just get you lying down. Just lie flat. That's brilliant. And you get your patient nice and relaxed. And what you're doing is you're looking at the patient's face. And this is if a patient has got instability following dislocations of the shoulder. Get your patient to go into abduction to 90 degrees, and then you go into external rotation, and you're watching your patient all the time. And you take it to where you feel that there's an end point there, and you're looking at your patient. And he's not got any problem with that at all. So that's a negative apprehension test. Just stand up for me again. The last sign I'd like to show you is called the sulcus sign, where you fix the scapula here, keep your thumb just below the AC joint there, and pull down. And you should get a little translation when you're pulling down. If you've got instability here in the shoulder, then that test will actually open up the shoulder, and you can get your finger right into that. That's called the sulcus test. So that's basically examination of the shoulder joint with a few tests that should allow you to identify where the problem is and what muscles are or tendons are actually affected. Thank you.